Well, good evening and welcome to another edition of Question Lab. I am your host, Jeff Downing, and I am pleased to be presenting a set of questions tonight based on renal. So, I think particularly renal physiology will be covered in tonight's session. Excited about that, and excited to introduce you to our our co-host here, Dr. Paris Vicaria. Paris, would you like to introduce yourself to the crowd?
Sure, thank you, Jeff. Hey guys, my name is Paris. I'm a dermatology resident here in Dallas, Texas. I originally graduated from pharmacy school and then went on to do further medical school. I'm also an RX coach with USMLE-Rx, so I work one-on-one with students such as yourselves to help prepare you all for the USMLE Step 1 and Step 2 CK as well. And I'm happy to help lead tonight's session.
Get ready for our first question. And you heard from Paris. He is one of the members of our RX coach team. I'm going to talk a little bit about RX coach later this evening. But one thing I want you to know is that the methodology that we're going to be using during tonight's session closely aligns with the way that we help our students prepare for exams and the boards. So some of the tips and some of the steps that we're going to be touching on tonight is definitely in parallel with the way that we help students like you prepare for the big test. Okay, so let's go ahead and get started with question number one. And as we reveal the question, again, if you're a first timer, you may look at this and you go, well, Jeff, it looks like there's something missing. I don't see any answer choices. Well, that's by design. We, we advise you to cover up those answer choices as step number one. And the reason we do that is, we feel like if you see an answer choice that you're unfamiliar with or that you don't feel like you know very well, that it can throw you off your game. So what we want you to do is to break these questions down methodically. And to do that, we say cover up those answer choices and start by reading the lead-in. And the lead-in is the actual question part within a test item. So in this case, the lead-in is which of the following is the most likely diagnosis? So we read that lead-in and we look at that. And the reason you want to do that is it helps you kind of key in on the type of information you might be looking for. So again, when you're kind of thinking about, well, how many steps will this question take for me to answer it? Or what kind of data should I be looking for from the vignette? That is helpful. So we read that lead in and then we read the vignette. A 66-year-old man comes to the clinic for routine follow-up. He has a history of type 2 diabetes mellitus, hypertension, and chronic kidney disease with a baseline serum creatinine of 2.2. He takes metformin, enalapril, and diltiazem. Physical examination is normal, and he feels well. Laboratory studies show serum sodium of 140, potassium 5.5, chloride 110, bicarbonate 18, creatinine 2.2, blood pH levels 7.3, and urine pH 5.2. So after that, we then reread that lead-in. Which of the following is the most likely diagnosis? Let us know in the question box how many steps you think this question will take to solve as I hand the microphone over to Paris. Paris?
Thank you, Jeff. So what we're going to do is we're going to kind of show you what we think are the important clues in this vignette and the lead-in, okay? And so starting off, generally the first thing you're going to get in a clinical question are the demographics. And in this case, it's a 66-year-old male, so an elderly male. So you want to make note of that because automatically that can start to clue you in into certain things that you should be thinking about, okay? Now, a lot of times then they're going to tell you, why is the patient coming to the hospital? Why are they there? And in this case, it's just for a routine follow-up, okay? Not any, acute issue like shortness of breath, chest pain, but routine follow-up. But we know there may not be, this question may not be as routine as it's made out to be. Probably something going on, as Jeff alluded to when we read that question. So in this routine follow-up, if you're seeing a patient as routine follow-up, you want to make note of what their chronic medical conditions are and what medications they're taking, what their lab values are. And as you can see, they're definitely getting at something with some of those lab values. You can see some of those are abnormal. So you want to make sure that you're interpreting each of those lab values appropriately to see which one is abnormal, which one's normal, and how do you piece it all together. Because at the end of the day, this is a one-step question. You've got to use all those pieces of the puzzle to come to a diagnosis. This question is asking us what is the most likely diagnosis. So one-step question, okay? So let's go ahead and let's take a look at those answer choices. And what we see here are 5 answer choices, okay? And when we work with students, we actually recommend that students start at the bottom of the answer choices and work their way up to the top. So start with E and then work your way up to A. And the reason we do this is because a lot of times we'll see students who start at the top, they'll see something they like and they'll select it without going through all the choices. So sometimes they'll get that question wrong as a result. So we recommend doing it this way to prevent yourself from biasing yourself. So let's go ahead and let's do that now. Answer choice E, type 4 renal tubular acidosis. D, type 2 renal tubular acidosis. C, type 1 renal tubular acidosis. B, hyperaldosteronism. And A, acute kidney injury. So we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Excellent. Thank you, Para. So we're starting off the night with a one-step question, which makes sense, obviously. It's a step 1 exam, but of course, they're not all one-step questions on step 1. So let's see how we do tonight. Interesting arrangement of answer choices here. We've got 3 types of renal tubular acidosis. Is that going to lead you in one direction or another? Or do you think that it's kind of a feint, trying to get you to choose one of those versus the other options? Based on the responses so far, looks like we've got kind of a mixed bag. So let's see, about almost 2/3 of you have voted. I'll give you a few more seconds. Let's see if everybody can get in there and make a selection. We always remind you that you should never leave a question unanswered on a USMLE exam. You are not going to be penalized for guessing. And you might get it right. Okay, 3/4 of you have voted, so I'm going to go ahead and close this poll, and we'll share the results. Okay, so a lot of you did feel like, hey, if they're talking about renal tubular acidosis, it has to be one of these 3. But there's no real consensus in terms of which type it is. So there may be some confusion about what these labs are pointing to. So let's go ahead and hide those results. We'll just remind ourselves that that answer choice D got the highest number of votes. And we will go and reveal the answer. And the answer choice, the correct answer is actually answer choice E, type 4 renal tubular acidosis. Seems like most of you are on the right track, but not everyone got the right type. So that's okay. Parse is going to help you understand how you get to the right answer now.
Thank you, Jeff. Yes, definitely a tough question, and renal tubular acidoses, or RTAs, are a tough concept, okay? So let's take a look at exactly what is going on in this question, okay? we've got a 66-year-old male who's got an elevated creatinine. Okay, so we know there's something going on with the kidney. We know this is a renal question lab as well. Okay. Now, if we look at that blood pH, we also know that that is low. That blood pH is below 7.35 to 7.45, so acidotic. Okay. So this patient has an acidosis. Now it's up to us to figure out if this is respiratory acidosis or metabolic acidosis. And you can see there that bicarbonate level is pretty low. So most likely a metabolic acidosis, okay? What's the next step? Well, the next step is to figure out if the anion gap is positive. Is this an anion gap metabolic acidosis? Or is the anion gap normal? A normal anion gap metabolic acidosis. And if you calculate the anion gap, it comes out to 12. Sodium minus chloride minus bicarbonate. That comes out to 12, and that's a normal anion gap. Okay. Now, our most common normal anion gap causes are diarrhea and renal tubular acidosis, like you guessed. Okay. But now let's talk about which type of RTA. Okay. If we take a look at the next slide, this is a nice kind of concise summary of your type 1, type 2, and type 4 renal tubular acidoses, okay? And one of the first things that you really want to do to differentiate is look at that potassium. If it's elevated, that would be type 4 RTA. Like our patient, the potassium was slightly elevated. So we know this is most likely type 4 RTA. Versus in the other two types, it's going to be low, okay? So automatically in this question, we know that this is most likely type 4 renal tubular acidosis and not type 1 or type 2. Okay, so if we go back to our question and we take a look at that potassium, we'll see that that is high and it is not low. Okay, so most likely this is going to be type 4 renal tubular acidosis. Type 2 and type 1 renal tubular acidosis would have hypokalemia. Okay. Furthermore, type 2 renal tubular acidosis is usually seen in children with a lot of inherited causes. Answer choice B, hyperaldosteronism, that would actually lead to metabolic alkalosis, not acidosis like we have here. Okay. And furthermore, that would also lead to hypokalemia, not what we have here. And then lastly, acute kidney injury. This is when you have an acute an acute decline in kidney function, and that would be measured by an acute rise in creatinine. However, what we see here is this patient's creatinine of 2.2 is the same as his baseline serum creatinine of 2.2. So not an acute kidney injury, okay? So the best answer choice here is answer choice E. So a nice review, hopefully, for you guys on RTAs.
Excellent. Thank you, Paris. Okay, so we're all warmed up here. It is kind of a tricky question, yeah, especially for kind of understanding the data points that you need to be thinking about to differentiate between these different types. So with that, you're ready for question number 2. And again, what we're going to do is we're going to cover up those answer choices, and we're going to start by reading the lead-in. Which of the following best pairs the patient's estimated free water clearance with the most likely diagnosis? Think about that. Think about the kind of information you're going to be trying to extract from the vignette as we begin reading the case. A 44-year-old woman is brought to the hospital by ambulance after having a seizure at home. She appears disoriented. Her vital signs are within normal limits. A urine toxicology screen and finger stick glucose are normal. Laboratory analysis shows serum osmolarity of 255 and urine osmolarity of 95, with a urine volume estimated at 4 liters every 24 hours. So again, which of the following best pairs the patient's estimated free water clearance with the most likely diagnosis? Let me know in the question box how many steps you think this is going to take as I pass it over to Paris. Paris?
Thank you, Jeff. So now let's take a look at what we think are the important clues in this vignette, in this lead-in, okay? So now we've got a 44-year-old woman, okay? So a different patient here, and we're told that she is coming in because of a seizure, okay? So whenever you have questions about a seizure, you always want to figure out exactly, what was happening around that time. Was she disoriented? Does she remember the event? Things like that. In this case, they tell us that she was disoriented, okay? So now we want to try to look for causes of that seizure, and they're giving us some information about a talk screen, glucose, and then also osmolarity levels, okay? And that's important because, as Jeff had read with this question, we knew that this was asking about free water clearance. So we knew that there might be a little bit of a calculation involved, okay? And so this question is asking us to not just figure out the patient's estimated free water clearance, but also to figure out the most likely diagnosis and pair it together correctly and find that pair in the answer choices, okay? So a couple steps here. I think we've got to calculate the free water clearance, 1. 2, we've got to figure out what the most likely diagnosis is, and then look for that pair in the answer choices. So let's go ahead and let's take a look at those answer choices. Once again, we will start at the bottom and we will work our way up to the top. Answer choice E, positive estimated free water clearance, diagnosis of primary polydipsia. D, positive, diabetes insipidus. C, negative, free water clearance, ADH secretion by lung cancer. B, negative, volume depletion. A, negative, thiazide-associated hyponatremia. So we will let you guys do a little math. We'll leave this up here for a couple seconds while you guys bust out your calculators, write out your equations, try to come up with that estimated free water clearance. You can get those osmolarity numbers. And then in a few seconds, change it over to the poll, and we'll let you guys select what you think is the best answer.
Okay, we're going to give you just a couple more seconds, and then we're going to go ahead and launch the poll. And we're going to also, after we break this one down, we'll talk a little bit more about examples of what a 1-step, 2-step, 3-step question might look like on the test. Okay, so let's go ahead and launch the poll. Go ahead and select the answer that you think best pairs that patient's estimated free water clearance with the most likely diagnosis. A little bit more, definitely a little bit more math with this one. Challenge level, moderate. Let's see how well you're doing here. So we've got about a third of you have voted so far. So let's go ahead and keep making your selections. Quick reminder that we will have a raffle at the end of tonight's event. Somebody is going to walk away with a subscription to RX 360 Plus. You do have to be here in order to win. We'll also have got a special offer for those who attend tonight. Pretty nice one. So hang in there. Okay, looks like almost 2/3 of you have voted, a little bit over that. So I'm going to go ahead and close this poll. And we're going to see what the results look like. So looks like the vast majority of you are thinking that it is positive here, right? So, and that answer choice E was the leading vote getter. So pairing it with primary polydipsia with diabetes insipidus as the runner-up. So let's go ahead and we're going to hide those results and reveal the answer. And the answer is indeed answer choice E, positive with primary polydipsia. Nice job, everybody. If you didn't get it right, that's okay. We're going to break it down right now. Turn it over to Paris.
Thank you, Jeff. Yes, great job, guys. This is definitely a tough question. So let's take a look at what's going on here. So the first thing, obviously, that we want to do is we want to calculate free water clearance, okay? As you guys can imagine, this really has to do with the ratio of the urine osmolarity to the plasma osmolarity, okay? And really, what it ends up coming down to is that ratio going to be more than 1 or less than 1, okay? In this case, the urine osmolarity of 95 over the plasma osmolarity or serum osmolality of 255 is less than 1, okay? So when you do 1 minus that, you're going to have a positive value, okay? So when you then multiply it by 4 liters a day, that comes out to a positive value. Now on the flip side, if the urine osmolarity was higher than the serum osmolality, that ratio would be more than 1. So if you did 1 minus that, it would be a negative value, okay? So in this case, even if you don't remember the full equation, knowing that to calculate estimated free water clearance, you need to know whether that ratio of urine to plasma osmolality is less than 1 or above 1. You can then figure out if it's going to be positive or negative free water clearance, even if you don't remember the full equation, okay? So a helpful trick or tip there, okay? So we've determined that this free water clearance is positive, okay? Now, what is the diagnosis then? Well, this patient's got low serum osmolality. That 255 is low, less than 280, and the urine osmolality is less than 100. So this suggests that the patient is taking in a lot of water, and we call that primary polydipsia, okay? If we take a look at the next slide, this is kind of talking about SI-ADH, okay? And actually, we'll go first to the second slide, one slide after this. And this is looking at causes of primary polydipsia, okay? So and that is, the definition of that is excessive water intake. And you can see there, the serum osmolality is low, okay? And the treatment for this is to restrict water intake, okay? Now, in the other forms of diabetes insipidus, you can see that serum osmolality is actually high. So this would not be a case of diabetes insipidus, okay? So if we go back to the previous slide, looking at ADH, what we can see here is that ADH has to do with water retention, okay? So in this case, we would not expect this patient to have elevated ADH levels as the cause of the patient's problem, because that would actually lead to water retention instead of what's going on in this patient, okay? So if we go back to our question now, we see there that we've got a patient with a low serum osmolarity and a low urine osmolarity, so primary polydipsia, okay? In the other cases, like diabetes insipidus, like we talked about, that serum osmolality would be high, okay? So answer choice D would be incorrect, okay? Now answer choice C, B, and A are all incorrect because it says negative free water clearance, but just to go through the other component of that, ADH secretion, answer choice C, that would actually lead to concentration of the urine, okay? So a high urine osmolarity, not what we have here. Answer choice B, volume depletion. This would also stimulate ADH and would also lead to high urine volume. You would try to retain water, not what we have going on here. And then lastly, answer choice A, thiazide-associated hyponatremia. In this case, you would also have concentrated urine and kind of a red herring in this situation. So the best answer choice here is primary polydipsia, as you guys picked up on. So great job on this tough question.
Yeah, definitely. Nice work, everybody. Yeah, I think a lot of you were moving in the right direction. And for those of you who missed it, hopefully that will provide you with the guidance that you're going to need to get that one right on test day. Because, this is going to be one of the topics that's going to get covered. So before we go to our next question, just want to take a minute to tell you about RX Coach. RX Coach brings you Question Lab every week. You get to hear from some of our talented coaches like Paris, and we get questions from students who are always thinking about, well, what I'm struggling with this particular block, or I'm struggling as I prepare for step one, but why would I go with RX Coach over other services? And for us, it's it's about the methodology, and it's about our approach and our support, and we really want to make sure that the plan works for you. And in order to do that, we start off with a 160 question assessment, and we analyze that report so that we get a better understanding of your strengths, your challenges, and the areas where you want to, focus your attention. And we use that, and we work to build a personalized study plan for you. So it's not we don't have a one size fits all plan, because every student is unique. Every student has particular areas where they do really well, or they don't need any help, and other areas where they sometimes struggle. So you get that plan, and then you get to work with one of our tutors in a one-on-one manner, right? This is not group tutoring. It's not you're not in in a live online course. You're actually working with an RX certified tutor who has helped students like you perform at their best on step one, step two, on COMLEX level one, level two, whatever your exam. We can support you. You also get access to all of the USMLE-Rx tools, including RX 360 Plus, which includes that digital version of first aid, as well as all of our RX bricks. So it's a complete learning and tutoring package for you. So if you go to the chat, you'll see that there is a link to rx-coach.com. You can go there, learn a little bit more about the program, and if you want, you can set up a free consult. And during that free consult, you can ask questions about how we, how we prepare students for these key exams. And if you like what you hear, we can pair you up with one of our certified tutors like Paris. So check it out, rx-coach.com, and we would love to work with you. So let's go to question number 3. And again, we're going to have a raffle here at the end of the night. So let's see what we've got here. So a little bit shorter question. We've covered up those answer choices, and we're going to start with that lead-in. Which type of transport is most likely being inhibited in this experiment? Look at that question, kind of think about what you need to focus on as we read the vignette. A researcher is studying the human nephron and the effects diuretics have on each segment. During his experiments, he uses a thiazide diuretic to inhibit a sodium transporter. So again, which type of transport is most likely being inhibited in this experiment? Interesting question. I'm going to pass it off to Paris to take it further.
Thank you, Jeff. So one of the things that Step 1 loves to ask is these scientific experiment questions. So they will give you a scenario and they can create their own conditions, which is nice. So they don't have to, doesn't necessarily have to be realistic, but they can kind of create their own scenario and their own results. So in this case, you definitely want to make note of anything you can about the study that's going to help you answer the question. What's the intervention? Who's being studied? How are they studying it? And in this case, they're asking specifically, as Jeff had read, about transport. Okay, so type of transport. And then when we then went to the vignette, we saw that this was talking about the nephron. So immediately, if we didn't know this was a renal question, automatically, things in your brain are going to start thinking about all the different transporters in the various segments of the nephron. Okay, and specifically the effects that diuretics have on those transporters. Okay, in this specific experiment, this researcher is seeing how thiazides inhibit a sodium transporter. So we're given a couple clues there: thiazides and sodium transporter. So this requires us to know the mechanism of action of thiazides. Okay, so this question is asking us what type of transport is most likely being inhibited. So one, we've got to know the mechanism of thiazide diuretics, how it works, what it acts on, and then two, on a molecular level, what type of transport is it that transporter does, the one that's being inhibited. Okay, so let's take a look at our answer choices and let's see what we're working with. Once again, we will start at the bottom and we will work our way up to the top. Answer choice E, secondary active transport. D, primary active transport. C, facilitated diffusion. B, carrier protein. And A, antiporter. So once again, we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Excellent, thank you, Paris. So again, not your typical step one question, but the kind of question that you will see from time to time. So not necessarily patient centered, but underscoring a key concept. So let's see, about a third of you have voted, so go ahead and make your selection. Which type of transport is most likely being inhibited in this experiment? Looking at the poll results so far, looks like one answer option has got a kind of a bit of a lead, but there's a the second place option seems to be gaining a little bit of ground. So let's see how it shakes out. Okay, I'm going to go ahead and close this poll, and we'll share those results. So primary active transport was the leading vote getter, with secondary active transport as the runner-up. So looks like over 2/3 of you had selected between one of the active transports. Let's go ahead and hide these results and see what the answer is. And the answer is E, secondary active transport. So looks like tripped up a few of you, but that's okay. We're going to break this one down as we always do with Paris. Paris?
Thank you, Jeff. Yes, definitely a tough question, but a really nice physiology question here, okay? So if we take a look at this question, this is asking about, transport. We know that this is thiazides, okay? So thiazides, if we take a look at the next slide, thiazides are a diuretic that work in the distal convoluted tubule, okay? And they work to inhibit that sodium chloride co-transporter. We call it a co-transporter because it is carrying along another thing with it, okay? Two things are moving in the same direction. Or sorry, two things are being moved. That's a co-transport, okay? This allows sodium chloride to be reabsorbed from the lumen into that cell, okay? Now you can see the sodium, once in that cell, then leaves the cell into the interstitium via that sodium-potassium ATPase, okay? And the chloride exits via a chloride channel, okay? So what is this sodium chloride transporter? Well, this is a symporter, okay? A symporter is the opposite of an antiporter. A symporter is something that moves two things in the same direction. You can see sodium and chloride are moving in the same direction. If they were to be moving in the opposite direction, one into the cell, one out of the cell, then that would be called an antiporter, okay? So that's that, symporter versus antiporter, okay? Now let's talk about active transport versus non-active transport, okay? So something like facilitated diffusion is not active transport. Basically, you have a gradient, a slope, a slide, if you will, that allows something to just move in a direction based on a gradient, okay? Not requiring energy. That's just facilitated diffusion or diffusion. Now, in this case, we can see that we need that sodium-potassium ATPase to create that gradient. Without that ATPase pump, we don't have that gradient, okay? So this is requiring energy, so it's called active transport, okay? So then we start talking about what's the difference between primary active transport and secondary active transport, okay? Primary active transport is when you are using energy or using ATP directly to move two things against a concentration gradient. So in this case, that sodium-potassium ATPase that's moving 3 sodium out and 2 potassium in, that's primary active transport. You are directly using that ATP to move sodium out of the cell into the interstitium and move potassium into the cell. That's primary active transport. Secondary active transport is when you're using the energy from elsewhere that has created a gradient and you're taking advantage of that gradient, okay? So our primary active transport of sodium-potassium ATPase has now created a low sodium concentration within the cell, okay? As a result, sodium is going to want to flow from the urine or the lumen into the cell, down that gradient. But the only reason that gradient even exists is because of the energy used in the sodium-potassium ATPase. So it is requiring energy, but it's not that specific pump that is inhibited by thiazides. Okay, so that's taking advantage of the energy gradient. That's called secondary active transport. Okay, so hopefully that made sense. So let's take a look now at our other answer choices, and we've kind of reviewed those. But hopefully now you understand what primary active transport is, facilitated diffusion, which does not require active energy. A carrier protein is something that binds the molecule and carries it in. In this case, we're not dealing with that. And an antiporter, again, we talked about how this is actually a sodium chloride symporter because they're both moving in the same direction. So this is a nice delve into receptor and transport physiology within the field of renal physiology.
Okay, excellent. Thank you, Paris, and thanks for that's a great little physiology mini lecture there. Hope everybody here enjoyed that. Shout out to Paris for helping us understand some things maybe you covered a while ago, or maybe you never quite fully understood. So hopefully everybody found that helpful. Okay, we're going to get into our next question, which is our final question of the night. But what I would like to do first is I'd like to ask Paris if you would just walk us through the differences between a one-step, two-step, and a three-step question. I know we've got a few new people here tonight, and maybe some folks that are not as well versed in this language. So, Paris, would you mind give us a quick breakdown with some examples?
Absolutely, Jeff. Happy to. So, when we talk about questions, when you have that lead in, that's kind of asking you the question, what is the most likely diagnosis? What is the drug, etc. You want to start thinking in terms of how many steps is that question asking us, okay? Now, if you have a clinical scenario and they're just asking you to come up with the diagnosis, that's most likely what we'd call a one-step question. You just got to piece together the clues to figure out what the diagnosis is. That's it, one step. Okay, now it can be a tricky one step, but it's just one step. Now, if this question were to say, instead, they were to give you that same clinical scenario, okay? They're not telling you what the patient has, but then the question says, what is the treatment of choice for the condition this patient has? Well, in that case, you've got to figure out, step one, you've got to figure out what the condition is the patient has, the same step one. But now two, you've got an added extra step. You've got to then know what the treatment of choice for that condition is. That's another step in that question. So a two-step question. So it adds another layer. It'll take a little bit more time and it requires you to know more, okay? But you want to know that as you're reading the question. Now, a three-step question could take it even further. What is the mechanism of action of the drug of choice for the condition the patient has? So in that case, step one, you've got to figure out the diagnosis. Step two, you've got to know the drug of choice. And step three, you've also got to know some pharmacology. What is the mechanism of action of that drug for the condition the patient has? So it's important to know those different steps so you can start thinking about them as you're going through the question. And you can make sure you're answering that question one step at a time and not missing any of those steps. So hopefully that helped clarify that for a lot of you people out there who are hearing this for the first time.
Excellent. Thank you, Paris. So hopefully that will help kind of clarify that as when we ask you to think about how many steps is this going to take for you to solve. Okay, final question of the night, and this is going to be a tricky one. So buckle up. So again, we're going to start with the lead-in, which is, as you can see, kind of far down the page. In this question, the lead-in is, which of the following best explains the persistent reduction in blood pressure at the end of the study? Okay, so a lot of cues here you need to be locking in on as we go read the vignette. A research study investigates the mechanism by which thiazide diuretics lower blood pressure in patients with essential hypertension. After administration of chlorthalidone to a group of 20 patients who were placed on a low-sodium diet, the following effects are seen. 1. Fall in plasma volume and a concurrent drop in blood pressure. 2. Gradual return of plasma volume to normal. 3. Mean blood pressure is lower than before the drug was given, despite the return of normal plasma volume. 4. Cardiac output stays at baseline in all subjects. Okay, there's a lot to take in there. So let's read that the lead-in again. Which of the following best explains the persistent reduction in blood pressure at the end of the study? Think about that. Let us know how many steps you think it will take to solve this one. A little bit challenging. Paris is going to kind of walk us through it. Paris?
Thank you, Jeff. Yes, definitely another tough question, especially with all those steps, okay? Now, we know this is another study question, okay? So this is asking us about another research study, and we want to make sure that we're understanding those different things that are being seen. Okay, again, we're looking at thiazides. Okay, so we're going to look at the important clues in this question again. And again, we're looking at thiazides and their mechanism by how they lower blood pressure. Okay, so they're then asking us, after administration of chlorothalidone in a group of people placed on a low sodium diet, they saw 4 effects. Okay, and you want to make sure that you understand those effects. You want to understand what it means by plasma volume falling, a drop in blood pressure. You then want to understand what's happening next. Okay, you want to understand how that plays, cardiac output plays a role in all of this. So a lot of important clues there. These are you definitely don't want to miss out on anything important in the effects that are seen from the research study, because this is asking us that at the end of the study, what is the explanation for why the blood pressure is still low? Okay. So we'll let you guys take a look at those steps, and we'll go ahead and open up the answer choice in the meantime. And once again, we will start at the bottom and we will work our way up to the top. Answer choice E, vasodilation. D, lower stroke volume. C, increased renal sodium reabsorption. B, decreased glomerular filtration rate. And A, arteriolar vasoconstriction. So we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here after you take a look at those effects. We'll talk about it in just a few seconds.
Okay, give me just a couple more seconds to take in all of that info. Remember, you've got what, roughly 90 seconds to get through a question on test day. So sometimes you're going to get these with the long vignettes or the multiple steps and lots of information to parse. Okay, so we're going to go ahead and launch this poll. Let us know, out of all of those things, that all of the effects that were observed, which of the following best explains the persistent reduction in blood pressure at the end of that study? Okay. It's like everyone's a little bit slow on the trigger for this one. There is definitely a lot to compute. This is a good type of question to practice with. Heard from one of our participants who noted that she saw one of the questions from tonight that we had posted on Facebook. Yep, we do that. We try to provide a little bit of thematic consistency from week to week. So yeah, sometimes you'll get a taste of what we're going to be tackling in Question Lab by following us on Facebook and Instagram. So make sure you're doing that. Okay, let's see. The votes are just trickling in here. Almost 2/3 of you voted. So go ahead, make your pick. Remember, you never want to leave a question unanswered on test day. And give you just a couple more seconds. If you're flummoxed, that's okay. No penalties tonight, okay? Okay, let's see. About almost 3/4 of you have voted, so I'm going to close the poll. Let's share those results. And boy, from the jump, vasodilation was the leading vote getter. Although about 1/4 of you were thinking lower stroke volume and decreased glomerular filtration rate, not far behind. So let's see what the answer is. We're going to hide those results and reveal the answer. And the answer is indeed E, vasodilation. Well done. Good work on that one, everyone. If you didn't get that one right, I can understand it. There was a lot going on in that question. So Pars is going to walk us through it. Pars.
Thank you, Jeff. Yes, definitely one of the tougher questions. So let's take a look at the next slide. And actually, let's jump ahead to the slide after that, looking at, again, our section on thiazide diuretics and first aid. Okay. So thiazide diuretics, as we know, they inhibit that sodium chloride reabsorption. Okay. And as we know, they're used to reduce fluid in the body, so they decrease plasma volume. Okay. They also, as a result, decrease blood pressure. We know that they're used for hypertension as well. Okay. Now, over time, that blood pressure is still going to be a little bit low. Okay, lower than previously. If you were to start this patient on a medication for hypertension, I would expect that the blood pressure would still be a little bit lower long term. Okay. But over time, you're not still necessarily losing more and more plasma volume, okay? Initially, you're losing some plasma volume through diuresis, but eventually that kind of returns a little bit to normal, okay? You're not going to be consistently in a hypovolemic state over the course of your life being on this medication, okay? So, we know this is the case and how thiazide diuretics work. But one of the other things that thiazide diuretics have recently been found to do is they actually are mild vasodilators. Okay? So this, in combination with that slight initial reduction in plasma volume, leads to that antihypertensive effect, a little bit of a vasodilation. Okay? So not only are we initially reducing plasma volume, but we're also getting a little bit of vasodilation from this drug that then helps to lower blood pressure. So if we go back to our question, if we take a look at those effects, we see effect number one. Yes, thiazides do have a decrease in plasma volume and do drop blood pressure. Yes, we know that about thiazides. We have now explained that plasma volume gradually over time returns to normal, okay? However, despite that happening, despite the plasma volume returning to normal, you still are at a lower blood pressure. So one of the only things that could really explain that of those answer choices is answer choice E, vasodilation. So even if you didn't know that thiazides can cause vasodilation, the other answer choices are all incorrect. We were told that cardiac output stayed the same, so the stroke volume could not have been lowered. Okay? Furthermore, answer choice C, B, and A would all actually raise blood pressure, not increase blood pressure, not decrease, but would raise blood pressure. So that you could automatically cross those off, like maybe some of you did at home. It's a great job. So hopefully this explains that question. When you're unsure of a specific mechanism, try to deduce maybe from the answer choices, maybe which of those answer choices are not correct. And then from there, you maybe just at one or two answer choices, and that becomes a lot easier as well. So another helpful trick there for you guys as well. So nice job overall in today's renal physiology questions. I will hand it back to you, Jeff.
Excellent. Thank you, Paris. And congratulations, everybody. This is, you did a nice job tonight. We're definitely happy to see that everybody's stuck with it tonight, stuck with the program. And hopefully you learned a lot. We've got, I think one of the great things here is that, you've got a teacher like Paris who can really help you understand what's happening at the whether it's at the nephron level or what's going on